Okay, we're ready.
Okay. Bueno, muy buenos días a todos. Buenas tardes a algunos. Vamos a dar inicio a este webinar en tiempos de COVID-19. Va a ser la córnea en apuros. Cornea under pressure. So really, I'm very, very happy. I'm very, very, very grateful because we are sharing knowledge. And thank you so much for our invitations. Our professor, James Reidy from Chicago, George James Florakis from Columbia, from New York City, and Professor Rajesh Fogla from India. They are very, very well-known corneal doctors. And thank you so much for your time and for joining us in this webinar. Y muchísimas gracias a todos. Vamos a hacerlo en inglés y en castellano. Y voy a presentar por alphabetic order, and our first speaker will be George James Florakis. Florakis, in Spanish, se graduó en la Universidad de Columbia, donde hizo su residency training program in the Edward Hockness Eye Institute de Columbia, New York City, y después hizo su fellowship in cornea and external disease con Jay Krashmer at the University of Iowa. Actualmente él es profesor de oftalmología en la Universidad de Columbia, en el Hockness Eye Institute en New York City. Es chairman de la Medical Advisory Board of the Eye Bank of Eye Restoration New York, and actualmente es el presidente de New York Ophthalmological Society. He enjoys actively teaching medical students. He is with residents. He has his own corneal fellows at Columbia University. He was my mentor. Thank you so much. And I know you are living now very, very strange times. So thank you again, George James, and you can start whenever you want with your presentation. Thank you, James. It's an honor for me.
Thank you so much, Pablo. It's an honor for me to be here with you today as well. As I said earlier, hopefully next time we can do this with a glass of Argentinian wine all together. Let's see here if I can get this up right here. Okay. So what I'm going to be speaking about today is the increasing incidence of fungal keratitis in endothelial keratoplasty. This is something which is a relatively new phenomenon for us, and we are still debating on how to deal with it. So I'm going to give you an overview of how we got there and what we're doing about it. Okay, let's see here. My financial disclosures, I am a consultant for a few companies, but they are not relative to this talk. So in reviewing the most recent Eye Bank Association of America statistics, we can see here that it's very clear that the number of corneal transplants has been increasing steadily. And when endothelial keratoplasty started in the mid-2000s, it increased even more so, both in the United States and internationally. The use of domestic tissue has changed in terms of what we've been doing. And initially, back in 2010, there were about 50-50% penetrating keratoplasty versus endothelial keratoplasty. As you can see over the past decade, however, endothelial keratoplasty has far surpassed that of penetrating keratoplasty. As DALK in the United States is still quite low in numbers, perhaps because we have good availability of tissue and often penetrating keratoplasties are easier for us to do. And as you can see in this pie graph here, endothelial keratoplasty, both DSEC over here and DMEC over here, again, far surpass that of penetrating keratoplasty. For most patients that only have endothelial disease, DMEC is a wonderful procedure, and it is often the preferred procedure for many surgeons. And of course, we know that it is removing damaged endothelium and scraping it off, replacing it with donor endothelium and descemetase membrane, and either an air bubble or SF6 to keep that membrane in place. It is a procedure that I first did back, I think, in 2013 or so. And early on, this is an early procedure of mine. We inject the tissue, often in a no-touch technique. We remove our inserter. And then usually just a single suture. And we slowly unfold the tissue. And again, either with air or SF6, we position the tissue, and pretty much a no-touch technique. The eye bank has afforded us an S stamp, which you can see here. And that S stamp helped us, especially early on, and even nowadays, for proper orientation. Here you can see the S a little better as the air bubble goes into the eye. So that's a wonderful procedure. And this was actually my first DMEK case. It was beginner's luck. My second and third did not look so good, but now I've done about 500, and DMEK is actually easier for me than DSEK, and obviously much easier than penetrating keratoplasty. So endothelial keratoplasty, or I like to call it tissue-targeted corneal transplant surgery, DALK, DSEK, and DMEK are now the preferred transplant options for most surgeons. DMEK in particular, you strip Descemet's membrane and endothelium from the recipient, and you only transplant a donor's Descemet's membrane and endothelium. About 15 micron surgery. The advantages are we have perfect anatomic replacement of the removed Descemet's membrane. There's no stroma to stroma interface. We have better and quicker visual results. Often one suture, small incision, and a very low rejection rate. Many studies quoting about 1%. However, something that's been accompanying the increase in endothelial keratoplasty has been the increase in incidence of fungal keratitis. Post-corneal transplant infections are indeed more common in DALK, DSEK, and DMEK, and they usually present as an interface infectious keratitis. I'm going to call that IIK, interface infectious keratitis. Some of them can be limited to the interface, but it can be bad enough to lead to endophthalmitis and even loss of the eye. Bacterial infections with PK were about 0.08%, 8 in 10,000. With fungal infections with PK, it was rare, 0.12 to 0.14%. However, when you look at results of endothelial keratoplasty, it is doubled to 15 in 10,000. So now, and especially more so in DMEK rather than DSEK. So we have a review of a couple of studies with major reviews have shown a significant increase in fungal keratitis post-endothelial keratoplasty. And it often presents as an interface opacity, which you can see here and here. And in the deep beam here, you can see that it's deep in the stroma. Sometimes it's accompanied with neuritis or inflammatory reaction. Sometimes you might just see small opacities. So the questions arise as to why is this occurring? One theory is that we're warming the tissue at the eye bank. And other questions arise, should we be treating an asymptomatic patient if we have a positive rim culture? Are the rim cultures really predictive? Should we prophylax all donors? In other words, should we have something in the preservative media to prevent fungal infection? And finally, if we get a patient with clinical infection, how do we treat them? Topically, orally, or surgically? And do the medications really work? So let's review some of these questions and see what the literature shows us up to this point. Fontana and his group in the BJO in 2019 reviewed the literature and reported 17 cases reported in literature, 17 case reports, a total of 31 cases of fungal interstitial interface keratitis, infectious interface keratitis after endothelial keratoplasty. In most of these cases, because the infiltrate is deep and culture was not available by scraping the cornea, the diagnosis was made by either an aqueous or vitreous aspiration, or if the lenticule, the DSEK or DMEK, was removed, by cultures of the explanted lenticules. The most common organism was either Candida, albicans or glabrata. Of these 31 cases, 28 had rim cultures. Not all doctors do rim cultures. But of those 28 rim cultures, only 15 were positive, 13 were actually negative. So the rim cultures may not be that sensitive. What about predictability? We're not sure of that either, and I'll discuss that a little bit more. The median time in this review of the literature showed that the time of infection was about 28 days with a range of 1 to 20 days. And oftentimes it was insidious. Patients might only have slight redness or minimal inflammation, a cell or two to begin with. Infiltrates often start at the interface, but then they can extend to all layers of the cornea and can actually, as I said, lead on to further destruction and even endophthalmitis. Here again, we see some small infiltrates. If there were one or two small ones, you might miss them. And this is a case of Candida glabrata in Dr. Fontana's papers. So what do we have right now? Well, right now we've got a wonderful preservative media which has been developed over the decades. Optisol GS is a sterile buffered culture medium. Has an osmotic agent, dextran, to keep the tissue from swelling. But most importantly, from our discussion here today, it has gentamicin, sulfate, and streptomycin, gram-negative and gram-positive coverage. No antifungal coverage. So what's going on? Well, there was a paper written by Dr. Brothers and with Elmer too in Chicago, talked about the eye bank's role in corneal transplant surgery, specifically in endothelial keratoplasty. The eye bank, for many surgeons, pre-cuts the tissue. It pre-strips, it stamps the tissue, as I showed you earlier, and sometimes even preloads the tissue for DMEK. And this may be why there's an increased rate with DMEK compared to DSEK. All of these procedures require warming of the cornea to room temperature. Perhaps the Optisol, which is great with its gentamicin and streptomycin, kills the competing bacteria and actually may be potentiating fungal growth because the competing bacteria are no longer there. So warming the tissue may have a role in the eye bank. We also have a situation where we have sequestering of fungus in the interface. So normal mechanisms which might clear a bacteria or fungus from the patient's normal immune system may be protected because it's sequestered. And as I mentioned earlier, there's no antifungal activity currently in the media. What about the donor rims? Well, with penetrating keratoplasty, we've decided, I think as a group, that bacterial cultures of donor rims have very poor predictability of infection. And because of this poor predictability and the fact that with penetrating keratoplasty, we had rare fungal infections, in the United States, only 25% of people actually culture the donor rim. And if you do get a culture, most surgeons will ignore that culture result unless a patient had a clinical infection. But what about positive fungal culture results? Conventional thinking would suggest that there's also poor correlation. Let's look at the data. Dr. Lissell in Iowa looked at 3,414 cases, and they found in that review that 71 of these cases, 2.1%, had a positive fungal culture donor rim. 4 of those 71 cases developed fungal keratitis. So 5.6% of the positive fungal cultures developed a fungal keratitis. And a positive fungal donor rim increased the risk of fungal endophthalmitis. In all those cases, surgery needed to be done to eradicate the infection. In their series, with a small n, they found, remember 4 cases, they found that empiric antimycotic prophylaxis initiated at the time of the positive culture reduced their incidence from 15.8% to 1.9%, but because of the sample size, this was not statistically significant. So going to a number of national, international meetings, people have been discussing this, initially based on that early paper, and there seemed to be no consensus whether to treat prophylactically in the absence of clinical infection. And if prophylactic treatment was started, the question was, which medications? Should it be topical? Don't forget, topical medications cannot penetrate that well into the deep stroma. Should it be oral? And again, do the oral medications penetrate well? Should it be intrastromal? And which should we use and for how long? These are all questions debated at the meetings, and people felt pretty strongly that yes, you should treat, or no, you should not treat. So let's look at some literature which might support one of those conclusions or the other. So do you treat a positive rim culture for fungus in the absence of clinical infection? Kurtzman, with 2 cases in their paper, basically decided to treat all patients with topical amphotericin B and oral fluconazole. Vislicel, the one that did the large retrospective review of over 3,000 cases, had a retrospective review and therefore did not have a standardized regimen. So when they reviewed their regimen, they saw that 22.5% of patients received topical treatment only, either amphotericin B, fluconazole, or voriconazole. 2.8% received oral only, fluconazole, voriconazole, or itraconazole, and 47.9% received both topical and oral. 26.8% received no prophylactic treatment. At the conclusion of their study, they recommended 3 months of treatment, although it wasn't clear which treatment should be recommended. Others have said no, there's low predictive value. For one thing, the onset of clinical infection, although it was quoted in the early study that has an average of 28 days, it has been reported as late as 1 year after a corneal transplant. As I mentioned earlier, topical antifungals and oral antifungals do not penetrate well, especially with an intact epithelium and the fact that the fungus is sequestered in the interface. And oral antifungals in some patients can be dangerous, may interact with other medications they're on, may affect liver functions, and potentially could even be fatal. So the treatment options and the duration are not standardized. And in one particular case, which is going to come out in the AJO, I think this month, there was a recurrence after prophylactic treatment had been stopped a number of months earlier. So here we're going to have a nice OCT of the interface infection in a DSEC patient. And as I mentioned, the antimicrobials, specifically antifungals, struggle to penetrate the intact epithelium and reach the deep stroma. What about surgical management? Fontana also reviewed the literature, and they found 30 cases in the literature which did not respond to topical and systemic medical therapy. And in review of that literature, they saw that 30 cases needed surgical therapies in a variety of combinations, either penetrating keratoplasty, removal of the donor DSEC or DMEC tissue, pars plana vitrectomy, intrastromal, intracameral, and intravitreal antifungals, and often glaucoma procedures. 5 cases of the 30 reported cases in the literature showed endophthalmitis. So again, topical therapy may not be enough, but their conclusion was taking out the lenticule sooner rather than later helped to prevent endophthalmitis. Elmer 2 talked about injecting antimicrobials in the interface in the cornea. Others have talked about concerns that that might potentially rupture the posterior Descemet's membrane and lead to introducing fungi into the anterior chamber. So although that's been described, not everyone has done that either. Back in 2007, before we had this outbreak of fungal keratitis, people already started talking about adding antifungals to the media. Dr. Ritterban in 2007 did a laboratory study, finding that if he added voriconazole to Optisol GS, it did decrease the incidence of positive fungal rim cultures. Despite that fact, however, it has not been adopted due to questions as to what the proper dosage is to avoid toxicity, and the questions as to whether or not the fungal, the antifungal in the media would actually be stable enough. In Europe, I believe they use amphotericin B in the warm media. Don't forget, in the United States, we use cold media preservatives. But amphotericin is also unstable in solutions, which can decrease its efficacy even after a short while. In a new study, which is coming out again in cornea within the next few months, they talked about a solution called Kerasave, which essentially is similar to Optisol GS with the gentamicin and the streptomycin, with the addition of 2.5 micrograms of a milliliter of amphotericin. This may be an option. In their study of 22 corneas, they found that it was safe for the endothelial cells. They had no positive fungal rim cultures in cornea submersed in this cold storage media. they did have one positive fungal culture in their control in the Optisol GS group. Small study, but again, something which is being thought about and something which might be introduced in our media. The Eye Bank Association of America's official statement at this point is that there's a concern about adding antifungals to the media because the concentration is controversial due to concerns about toxicity and efficacy. So as of yet, the Eye Bank Association of America has not yet endorsed either voriconazole, amphotericin, or any other antifungal in the cold storage media, although it is something which is being explored and might be something which might be added in the future. So as far as fungal infection in endothelial keratoplasty, there are still many questions which remain. We know the onset for most patients are within the first 3 months, but it can occur as late as 1 year. I had one patient who did develop a interface infectious keratitis at approximately 8 months postoperatively. He had been 20/20 a visit before that, 3 weeks before that, and he came in with count fingers vision, who ended up having endophthalmitis and multiple intravitreal injections. Is there a role for prophylaxis? Should we treat positive rim culture? Well, 2-3 years ago, when I had that patient, I probably would have said, I'm not really sure. The evidence is not there. But now, since that patient, I've had 2 positive rim cultures, and I've been treating with oral fluconazole and topical voriconazole. Whether or not it makes a difference, we don't really know. We don't know what medications to use. We don't know what dosage. We don't know what route is best. I do also believe that early surgical treatment is indicated if it's not responsive to the medications, whether it's removing the lenticule or doing a penetrating keratoplasty. In my patient, I ended up doing a penetrating keratoplasty. And lastly, should antifungals be added to the preservative media? I think they should, but we do need to explore toxicity, effectiveness, and cost effectiveness. So tissue-targeted corneal transplant surgery has come of age. It offers significant advantages over conventional corneal transplant surgery. However, as we discussed here, DALK, DSEC, and DMEC have all been associated with a higher incidence of fungal infections postoperatively. As evidenced by the controversial and heated discussions at various international and national corneal meetings, the questions of prophylaxis, treatment in the absence of clinical infection, how to treat and how long to treat all remain to be further explored and standardized for this sight-threatening complication. Right now, our treatment strategies and clinical outcomes vary widely. I'd like to thank you, and thank you, Pablo, for inviting me. I can't hear you. I can't hear you.
Sorry. Thank you so much, George. An amazing presentation. Here in Argentina, really, we have a very long waiting list. We have not corneal tissue at all here, or it's necessary to wait a long time. So we obtain corneal tissue from the US. And here we have the same problem. I have a problem, a candida infection in a TAC procedure, and it was a nightmare. So perhaps we are concerned about the storage medium. Perhaps, you know, I know the papers, because sometimes here we use preloaded tissue. We are in trouble. So thank you so much for your presentation. I don't know if somebody wants to ask somebody to George. James Florakis, thank you so much for your nice presentation.
Thank you, Pablo. Thank you.
Very good, George. Thank you very much. I have the problem with the fungal with a DSEC in a patient with only one eye.
Oh, wow.
I tried to put all the drops and pills, and nothing happened, and made a penetrating keratoplasty, and it continued with the rim out of the cornea. And maybe in 1 hour, I will be taken out with a 9.5 penetrating cornea keratoplasty to try to take it out with his only one eye. So
I also had, my one case is very similar. He has 2 eyes, luckily. But what I found when I did a penetrating keratoplasty, I found that there was white material sequestered in the capsular bag. So I ended up removing the intraocular lens as well as a second procedure because I was not prepared to do it initially when I did the penetrating keratoplasty. And that capsular bag did have fungal material in it as well.
Okay, great. Thank
Nightmare,
you.
A nightmare, really nightmare. Okay,
Yeah.
we'll continue with, because we are timing.
Just one point for George.
Yeah,
it's a wonderful presentation.
Thank you.
We in India, we have had reported cases of interface infection after using pre-cut DSEC tissues. However, because for DMEC, we prepare our own stripping of the donor, we have not seen interface infection following DMEC so far. So I think it's the time duration between the time the tissue has been prepared in the eye bank and stored in the donor solution, and by the time it's shipped to the surgeon, I think that may have some role. Just wanted to know in terms of whether in DMEC, whether there would be a role of some, giving an intracameral antifungal before you inject your donor into the eye, because you haven't yet transplanted your endothelial cells, and you give a intracameral injection of antifungal and then, put in your tissue. Would that reduce the incidence of interface infection, fungal infection?
Perhaps, as long as it's not toxic to the new cells.
George, do you prepare yourself your donor tissue during the DMEC procedure?
In DSEC, I cut my own tissue still. In DMEC, I started preparing my own tissue. I've done many at this point. My first 6 I did myself, but I tore 2 out of the 6 unknowingly. At that time, they had diabetes, and we did not realize at that time that diabetes was a relative contraindication for stripping tissue. But my hospital did not want to accept the costs anymore, so now the eye bank prepares it for me.
Okay,
But
well,
I do not use preloaded. I load it myself.
Could I make just a very quick comment here? For decades, they've been using amphotericin in almost all tissue culture media. And I just don't understand what the concern is on toxicity and the eye with amphotericin when they've been using amphotericin in tissue culture media for 3 or 4 or 5 decades. Doesn't make any sense.
Yeah, for some reason, the eye bank is holding back. I'm not really sure either, to be honest with you.
okay, thank you so much for your wonderful presentation. Now, thank you again to Consejo Argentino de Oftalmología, Argentine Council of Ophthalmology, and now his president by now is Pablo Daponte. Pablo Daponte, he's a very, very famous cataract and corneal surgeon. Well, thank you again for sharing your knowledge with us. Please start your case.
Okay, thank you very much, Pablo. And thank you for all to share with this incredible guys my short presentation. Okay, I will talk about Dalcan epithelial ingrowth. Well, it's not very common. We see that migration and growth of conjunctival epithelial cells into the anterior chamber, into lamellar interface of the cornea itself. Since Dr. Mohamed Anwar 20 years ago started with deep anterior lamellar keratoplastia, here in the third world, we started because it's very common here, Dr. Enrique Malbran and other doctors in Latin America prepare the anterior transplant and we have problems because they have different kind of interface. But with this big bubble technique of Dr. Anwar, we started and we gain a lot of very good patients in our work. But we preserve the endothelial, but not prevent epithelial, subepithelial, or stromal immune reactions. This is a work between Andres Gonzalez and Francis Price. They talk about this. And what happened with pathological ingrowth of blood and lymphatic vessels? Well, what happened with epithelial ingrowth? I want to talk about this. This is another work that I want to share with you with Ashbala Katak. They compare penetrating complications between penetrating keratoplastia and DALK. And we cannot see here what happened about epithelial ingrowth, but we have problem with loss of suture, resuture, edema, glaucoma, cataract, neovascularization, and descemet detachment. This is the case I want to present you. This is a 25 years old male with amblyopia in the right eye, with a corneal scar paracentral, and he has a problem. And since he has 11 years old, we think this happened with the herpes simplex scar. The right eye have a best correctional visual acuity of 2400, and the left eye is 2020. We prepare all the patient with endothelial cell count, the pachymeter in the left, and we can measure the scar over there to prepare the DALK surgery. We made it so well with a big bubble technique, and this is the photograph 24 hours later. This is the drops I used to put in all my patients. It all depends what happens later, but Cypret and prednisolone for 2 hours, and refresh tear. So what you want to the cornea surfaces. This is the OCT at day 12, because the cornea don't start to be so well. This the pachymetry is too high, and if you can see, the descemet and the line between the descemet and the residual stroma over there is too high. And I think what happened here, I need a rebubble and to try to push the descemet between the stroma. And here again, what happened at 1 month. And the patient have a problem with the plant, have an injury, a trauma with the plant in the cornea, but this occur because he don't have no epithelialization over the cornea. He have a big ulcer all around the cornea, and it happens in 1 month later. He have an abscess that I prepare and put a lot of drops over the eye. And here what happens, the total descompensation of the cornea. I want to share with you the video, to the ReDALK video about this patient. I took out all the sutures, and with this forceps, slowly try to separate the bottom of the cornea between the descemet. I don't want to make this very hard because, you know, perhaps we have a scar over there and broke the descemet membrane. If you can see what happened with the stroma over there, and I put a sponge over the cornea, because I can see what a sticky substance over there that I think may be epithelial. I'm not so sure, but I try to remove all of this. I take a lot of time because it's very common in surgeries in excimer laser and LASIK surgery, and I used to take it out all the epithelium. So I think this is maybe the same. I want to take out all the residual stroma because I think this will not be very good to put all the cornea, and stitch all and put all the sutures. This is the patient 24 hours later, and 2 months later with 2100 best correctional acuity in his left eye. He continued with drops, and I don't take out any suture because it occurs only 4 months ago. And what happened with this, I think, what is the potential physiopathology? I think that we have a step between the donor cornea and the residual cornea and the host, and this step make to the ingrowth of the epithelial cells, and they put down between the cornea donor and the host. And I think this appear, and because all the stroma of the cornea, the donor cornea, don't have the sufficient oxygen and all the things that would give not only the tears, but even the epithelial. I think this, I couldn't find another case like this in PubMed, and I think it's not very common, but I don't have, thank you very much. I want to take this out. Mm-hmm.
Nice presentation, eh? Very, very nice presentation.
Okay.
Congratulations.
Thank you. Thank you.
Any comments? Dr. Fogla? You have a very, very,
Yes.
a lot of experience in dog.
I'm afraid about it.
No, it's a nicely managed case. And you mentioned that the original indication was a herpetic corneal scar. So with the non-healing epithelial defect, I would look at if there is some element of neurotrophy involved, because these patients, sometimes the epithelialization may take longer. And also when you have significant amount of stroma in the periphery and you put in a full thickness graft, you may be able to compress the area where you're suturing to match the edges. But in between sutures, there is like a small step deformity and the epithelium is not able to bridge over that. And that's why you have a epithelial defect persisting for a long time. And a non-healing epithelial defect remaining for a long time can itself lead to secondary infections. And intraoperatively, what you picked up with your Merocell sponge as the epithelium, I'm not very sure whether that's because usually epithelial ingrowths are not very clear. They will have a grayish kind of a little bit of a, abnormality that you can see. And the other thing is because you had inferior bleeding from the inferior graft-host junction. Sometimes when you have a lot of bleeding, the bleeding can also lead to something like a fibrin formation, which when you pick up with your Merocell sponge, it might look like a sheet. But I think you did a great thing by trimming down the stroma. And then when you put in your graft, you were able to get a better apposition at the peripheral edge. And I think these kind of cases, sometimes when we anticipate that there is likely to be a possibility of a delayed epithelial healing, you can combine your DALK with an amniotic membrane transplant at the same time. So the amniotic membrane protects the epithelium in the immediate postoperative period and avoids having to deal with a persistent epithelial defect later on.
Great, thank
Nice
you.
thing.
Thank you, I appreciate it. I'm not very sure that this is epithelium. I don't give this to pathology. That's a
Yes.
mistake that I made, and perhaps I don't want to have another case like this, so perhaps maybe the only I will have, but good idea about to put over the cornea the membrane, the amniotic membrane. Yeah, thank you very much.
And perhaps add valcyclovir or acyclovir.
Yes, yes. So for all corneal scars where we don't have an exact etiology in the patient's history, and we make a clinical assumption of viral etiology, we do give them oral antivirals, at least for the first 3 to 4 months, while they are using steroids more frequently. And as we taper down the steroids and they use it only once a day, or maybe using softer steroids, that point of time, maybe you can discontinue the oral steroids.
Okay.
Professor Florakis and Professor Reidy, why do you think it's not so popular a DALK procedure in the US? Tell us the reason. Why not? What do you think about it?
I think we have a lot of inpatient surgeons in the United States, and it's technically a little bit more difficult to do for them to get the big bubble. I think there have been suggestions in the change in the procedure to standardize it, which have made getting the big bubble much more likely. In my opinion, almost every patient that you would, 20 years ago consider always doing a penetrating keratoplasty, we really should be doing DALK. So I think it's a little bit more difficult to do, takes a little bit longer. So a lot of people don't want to, unfortunately, take the time to do it. But I think it's a great procedure, and I would always try DALK first before I went to penetrating keratoplasty.
I also think it's a great procedure, technically difficult, more so than penetrating keratoplasty. I unfortunately happen to have a fairly high rate of rupturing Descemet's membrane. Many of those perhaps I should have saved, but because of my insecurity, I end up converting. So what happens for me is when I do a DALK, I end up having, let's say, a 20-year-old patient with keratoconus, and I have a 3,000 cell count donor or a 2,200 cell count donor. I'll take the 3,000 cell count donor, and because of that, if I rupture Descemet's, I'll say I'll give them the 3,000 cell count donor. In other words, I don't have confidence enough in my DALK, so I end up converting more than I should perhaps. But it's a great procedure, I think.
And also one of the reasons is I think your reimbursement rates are the same.
Or lower.
And lower.
Lower.
Yeah, and you take more time to do compared to a PKP. Yeah. And initially in the learning curve, the visual outcomes may be inferior to what you can get with PK. So I think these are the hurdles which people feel that, if I had done a PKP, my patient would have seen much better. Whereas when you do a DALK and you fail to achieve a big bubble and you do a manual dissection, the visual recovery is delayed. That means your patient initial visual acuity may be in the range of about 20/80, 20/60, and to reach 20/30 or 20/20, it may take 1 to 2 years. And so that's the reason why people feel that maybe a penetrating keratoplasty, which anyway has a good long-term survival in indications such as keratoconus. So I think the tendency not to shift to DALK is pretty common.
Great, thank you so much. Now, because of the time, I'd like to introduce Dr. Rajesh Fogla from India. He's a specialist in cornea and external disease and cataract and refractive surgery. Areas of interest, of course, laminar corneal surgery, refractive surgery. He has a fellowship of the Royal College of Surgeons of Edinburgh in UK. He is actively involved in teaching and training, instruction courses at various international and national meetings, fellowship program. He has his own training courses in cornea over the past 20 years, routinely conducting courses at the American Academy, a lot of publications, achievement awards at American Academy, a gold medal from Intraocular Implant and Refractive Society of India. Okay, thank you again, Rajesh. I know it's a very, very strange time. Thank you for your presentation. It's an honor for me. You can share the screen.
Yeah. So what I'll be talking on is surgical management of extreme ectasia. Being in a referral practice, my colleagues are very kind to me and they refer all these kind of cases. So let me just share with you certain clinical scenarios where we'll be able to see how we manage those cases. Now, looking at large diameter DALK. Now, this is a 55-year-old gentleman presenting with extreme amount of astigmatism, at about 19 diopters of astigmatism. And when you see on slit lamp, you can see this is a case of pellucid marginal corneal degeneration. And this gentleman was unable to wear a scleral contact lens. So we looked at what kind of surgical options that we have to manage this case. One of the procedures that I've done earlier is trying to do a wedge resection inferiorly, which again, it's you can get initial good results, but over a period of time when the sutures are removed, the astigmatism tends to come back. Doing a crescentic lamellar graft inferiorly or a banana-shaped graft inferiorly also is surgically a little bit more challenging, induces a lot of astigmatism, and takes, for visual recovery to happen, it takes a long time till you remove the sutures and the patient can see much better. So what the approach that we did was basically what we have learned from our DALK. So here I've used a large 11 millimeter trifine, done an eccentric trifynation after doing an inferior limbal peritomy as well. So we take off the anterior 40% of the cornea by doing a lamellar dissection. We create a big bubble in the center, 7 millimeter, expose the pre-Descemet's layer, and then the peripheral stroma is trimmed down. You can use a lamellar dissector or use a pair of scissors to kind of trim down the stroma. And then we put in our graft and secure with interrupted sutures. Now that's the post-op appearance. You can see that it's a fairly large size graft. And if you see on the slit view, now you can see that the corneal curvature looks pretty normal. And his astigmatism was only 2 diopters, and he could improve to 20/30. And that's his pre and post-operative topography. You can see there's a huge amount of astigmatism, and post-operatively is doing pretty well. So we have done over 14 eyes with pellucid marginal using this technique, and they have done fairly well over the past 8 years. Now, this is another situation where this is a 29-year-old male with progressive decrease in vision. The fellow eye was blind from prior trauma. And here his corrected vision, best corrected vision was about 20/100. And then you can see that it is a severe ectasia, a keratoglobus. This is how it looked in the OR when we took him up for surgery. And it's quite challenging. And the corneal diameter appeared to be about 16 millimeter. So what we did was we performed a limbal peritomy. And while performing the limbal peritomy, we extended that a little bit into the cornea so that we could harvest the limbal stem cells onto the conjunctiva. There was some amount of corneal tissue in the center. So we did an initial just about 150 microns of trephination, a 6 millimeter, just to try and debulk the cornea in the center. Went ahead, made a peripheral groove in the sclera. And then from the center point, we started doing a lamellar dissection to the peripheral part. This part was the thinnest part, and we did anticipate that we will encounter perforation or microperforation at some point of time. The donor cornea was fashioned manually. We prepared from a cornea scleral rim, taking about 1.5 millimeter of sclera in the donor. We continued with our dissection in the host cornea, completed that. And after we finished that, we did encounter some perforation, 2 perforations. That's why the air in the anterior chamber secured the donor cornea, the large donor cornea scleral rim in place. And then we closed the conjunctiva on top. We had done an inferior peripheral iridectomy, and I left behind an airfill to avoid any kind of double anterior chamber. So that's the post-op appearance, comparison between pre and post. And this patient, you can see, did very well. And he's still at 3 years follow-up, maintaining a vision of 20/30. The cell count appears less, 1,285, because his cornea was so stretched. I think because of a larger surface area, the overall cell count appeared a little less. But the corneal thickness was normal. That's his corneal topography, K values of 44.5 and 46.2. And that's how it looks on Scheimpflug imaging. You can see between pre and post. Now, what about something like a tuck-in lamellar keratoplasty? So this is another case with extreme ectasia, had blue sclera as well. The fellow eye was blind again from a previous trauma in childhood. And in this eye, there was a Descemet's rupture as well because of extreme stretching of the cornea. So we went ahead, and in this patient, what we did was we did the pachymetry, and we found that there was about 300 microns of stromal tissue in the periphery. So we used a 10 millimeter trephine to create an impression, and then we used a diamond knife to make the groove of 200 microns. We dissected out the lamellar tissue, and then we did a back dissection to create this lamellar pocket beyond the edge of the trephination. The donor cornea was mounted on the artificial chamber, and then we used a diamond knife to make the groove. And after that, we did the back dissection, trimmed out the peripheral anterior stromal tissue, and then punched out a nice 10.5 millimeter graft. So this ledge was tucked into the pocket that we made in the periphery, and then the cornea was sutured. And a bandage contact lens was placed in. That's how the post-operative appearance. And you can see that despite having a large DM rupture, the patient's cornea was still relatively clear. So the plan was that if the patient is not happy with the vision, and if we need to go back, maybe we'll go back and try and do an endothelial keratoplasty at a later stage. What about epikeratoplasty? Now, this is again a patient who had keratoglobus, extremely thin cornea. So this was done almost 13 years back. So what we did was we did the peritomy, again, saving the limbal stem cells on the conjunctiva, applied alcohol to the epithelial surface, did the epithelial debridement. It's very important when you do an epikeratoplasty that you need to remove the epithelium completely. If you do not do that, you will tend to have epithelial ingrowth, epithelial nests in the interface. The donor, again, because it's pretty large, it has to be prepared manually. So we do mark about 1.5 millimeter from the limbus and cut out the remaining part of the sclera. Sometimes you can trim the sclera from the posterior aspect as well. And a paracentesis is necessary because you have to flatten the cornea. So you do a paracentesis to release some aqueous, put in the donor tissue in place, and secure it with episcleral bites. What I do now is I make a small scleral groove when I'm taking the sutures, because I found that if you place the sutures only on the surface, over a period of time, this surface kind of cheese wire through the episcleral bites, and you find that your graft is kind of coming back. So you find that there is some recurrence of the keratoglobus. Whereas if you make a groove in the sclera and then you pass your sutures through the glue, there is some amount of fibrosis that takes place between the edge of the sclera and the scleral groove, and that prevents the the slippage of tissue to be recurrent. So this is another patient where we did a similar procedure. So again, a keratoglobus with a spontaneous DM rupture. So in this case, when we performed the procedure, we also went in, because this appeared to be fairly recent. So we, after putting in the graft in place, we did an airfill, and then using a reverse Sinski, we tried to see if we could oppose the torn edges of the decimates. Because this was of recent onset, the patient had a sudden decrease in vision just a month back. So we looked at the OCT, the edges still looked slightly curled, like what you see at the edge of a DMEC graft. So we went in and we tried to close the gap that we had. And you will see some folds because there is significant amount of larger amount of surface area. So that's how the eye looked post-operatively. And this patient also recovered about 20/60 vision post-operatively. Did have a cataract, which required a cataract surgery subsequently. There's another patient with a patient who had undergone an epikeratoplasty, and she has a follow-up of more than 12 years and still maintaining fairly good vision. There's no limbal stem cell deficiency, and with the contact lens, she is still able to manage her day-to-day work. Combined procedure. So this is again a patient with extreme ectasia, a keratoglobus, but this patient had a central corneal scar, possibly from a previous eye drops-like episode, because it was very difficult to determine looking at the clinically at the cornea and on anterior segment OCT. So here, when we tried to do the same procedure as we had been doing earlier, we started dissection. However, when we reached the central part where the scar was there, we ended up creating a big opening there because the scar was, it was very difficult to dissect through the scar. So what we did was I went ahead, this was done under general anesthesia, so I had the luxury of taking time for the surgery. So we enlarged the opening to a 6 millimeter opening. Then we had, luckily we had a second tissue available with us. We prepared a dissect lenticule of 6 millimeter, put it over the opening, and then we put in a large corneoscleral graft in place, secured with suture, put in an air bubble in the anterior chamber, then brought the dissect lenticule back in place, and we closed the conjunctiva on top. So that's how it looked at the initial postoperative period. And this is at follow-up, you can see the patient regained 20/20 vision. So this was a combination of being a large diameter, a lamellar graft, and a central dissect graft, something like a mushroom keratoplasty. So basically, in extreme ectasia in the surgical management, you can look at the options of doing an epikeratoplasty. When the entire cornea is very thin, there is no space for you to do any kind of lamellar dissection, then you can resort to doing an epikeratoplasty, build up the corneal volume, and then if the patient requires further improvement in vision, you can always come back 3 to 4 months later and do a central penetrating keratoplasty. If there is some amount of tissue that you can dissect, you can do a large diameter dowel. If the peripheral corneal thickness allows you to do some dissection, you can think about doing a tuck-in lamellar keratoplasty. The advantage of tuck-in lamellar keratoplasty is that you don't disturb the limbal stem cell population. So you make your trephination just ahead of the palisades. and then you can do a back dissection and take support from the peripheral sclera. And in rare situations, you may have to take a combined approach of doing a talc with endothelial keratoplasty. So thank you for your patient hearing.
Congratulations, Rajesh. Really amazing presentation. He's a great surgeon. I don't know if somebody wants to ask something to Rajesh. Really, I have not experienced in keratoglobus. We have
my colleagues are very kind. They tell all these patients that you get 20/20 vision, and they write a nice referral note. And I have these patients in my clinic, and then I'm sitting scratching my head, wondering what to do for these kind of cases, because some of these cases may require multiple intervention if there are post-operative complications. So it takes up a lot of chair time and also a lot of surgical planning. And especially if you have such a large graft and you have to convert to a PKP, the risk of it will become like a high-risk graft with very high incidence of rejection episodes. So this again requires some sort of surgical experience and planning to be able to do these kind of extreme cases. But they are very, very gratifying when you do them and you can restore back to the normal corneal contour. It makes a big difference to the patient's life.
Incredible. Thank you again. Really wonderful presentation. Okay. Our next speaker is Gustavo Galperín from Argentina. Gustavo Galperín is a corneal expert. He has a corneal fellowship. He has a lot of teaching activity here in Argentina. And thank you again for joining us. You can share whenever you want our screen. Thanks. Gracias, Gustavo.
Thank you very much, Pablo. I'm very thankful to participate in that important event with great sessions. I will show my slides in English and we speak in Spanish for our Argentinian audience. In my next slides, I will show some cases y la importancia de utilizar la keratoplastia penetrante o lamelar en forma terapéutica o el recubrimiento conjuntival en casos de infecciones corneales severas. Let's talk first about conjunctival flap. ¿Por qué lo realizamos? Porque es un parche biológico, porque aporta tejido fibroso y vascular que genera confort al paciente y favorece la rápida cicatrización de las lesiones y favorece la llegada de inmunidad al área comprometida de la córnea. ¿Cuándo lo realizamos en nuestro medio? Cuando el tratamiento médico fracasa, cuando hay un adelgazamiento progresivo de la córnea con riesgo de perforación, cuando luego, por ejemplo, una infección con sospecha de ser micótica o de cantamoeba, le realizamos una biopsia y requerimos hacer un recubrimiento para ocluir la keratectomía que hemos realizado. Y también, lamentablemente, nuestro medio, como el doctor Chiaradía nos mencionó, cuando nos falta tejido es uno de los recursos más útiles, sobre todo en infecciones severas. ¿Cuándo no lo realizamos? Cuando hay perforación, porque si realizamos un recubrimiento conjuntival cuando existe perforación de la córnea, habitualmente, como en la diapositiva de la derecha a central, obtenemos una cámara anterior central o una pseudocámara, y si hay una infección descontrolada e involucra la mayoría de la córnea, al cubrir toda la cámara anterior, perdemos la posibilidad de divisar qué está sucediendo. Hay algunas oportunidades donde tenemos perforaciones, que son indicaciones de keratoplastias, pero lamentablemente no tenemos tejido en las primeras 48 horas, debemos resolver el caso, y un recurso muy útil en los últimos años, sobre todo en el ámbito público. Muchos de nosotros trabajamos en el ámbito público, en public institutions, y la excepción es utilizar el tejido escleral. Scleral patch es very useful, es muy útil porque nos permite tapar o ocluir una perforación. Over the scleral patch we use conjunctival tissue, le ponemos la conjuntiva sobre este parche de esclera y nos ofrece una solución viable en casos desesperados donde no tenemos tejido para reparar. Algunos pequeños tips en la realización de los recubrimientos conjuntivales. Primero, no debe ser realizado por un cirujano principiante que no tenga experiencia, porque es una cirugía que no puede fallar. Aún así, si no respetamos algunas pequeñas perlas, puede fallar. Y básicamente debemos respetar el limbum corneal para no dañar las células stems, por si en el futuro tenemos que realizar una keratoplastia. De ser posible tomar conjuntiva vulvar inferior, ya que tomando conjuntiva vulvar superior tenemos dos posibilidades de complicaciones. De tosis por tomar fibras del elevador del párpado, y por si estos pacientes requieren, muchos de ellos sí lo requieren, cirugía de glaucoma en el futuro, por lo tanto, comprometer la conjuntiva superior puede comprometer una cirugía de glaucoma. Tratar de planear que la cantidad de tejido obtenido conjuntival sea por lo menos un 30% mayor a la superficie a cubrir, y en caso de realizar un recubrimiento de toda la superficie corneal, que sea no menos de 14 milímetros de tamaño. Liberar el epitelio alrededor de la lesión para no generar quistes epiteliales por debajo de la conjuntiva, y intentar de que no haya ningún tipo de tracción para que no tengamos ninguna de estas complicaciones. Algunas complicaciones, como todo procedimiento quirúrgico, no está exento de complicaciones, y las más frecuentes que vemos son la isquemia del flap, cuando tomamos por error muchas veces tenon y no conjuntiva, la perforación del flap, que suele ser un evento intraoperatorio que es difícil de reparar, la retracción del flap cuando tomamos poco tejido o está demasiado tenso, y la aparición de quistes epiteliales, como en la foto inferior, cuando no realizamos la epiteliectomía correspondiente antes de poner el tejido conjuntival sobre ella. Algunos casos, este es un caso de una mujer, female, con una infección de Staphylococcus aureus, parálisis facial, una infiltración de 5 milímetros de diámetro, muy pobre respuesta al tratamiento, peligro de perforación, adelgazamiento progresivo de la córnea, no había tejido corneal disponible, ya que probablemente hubiera sido candidata a una queratoplastia penetrante, ya que había margen libre. Le realizamos un recubrimiento conjuntival que logró curar y enfriar la situación. Este es otro caso posible de una paciente añosa, con bajo potencial visual, donde lo que vemos es pérdida de sustancia corneal como consecuencia de la lisis posterior a un infiltrado corneal, a un infiltrado infeccioso. Por lo tanto, la solución en estos casos es el recubrimiento conjuntival. Liberamos la posibilidad de una infección posterior por un defecto epitelial. La cantamoeba es un caso especial, ya que la cantamoeba, como los vamos a ver como los elementos fúngicos, tiene la posibilidad de mantenerse latente en el estroma profundo. Por lo tanto, si bien existen algunas publicaciones que dan tasa de éxito en queratoplastias penetrantes y algunas con queratoplastias lamelares, lo indicado es tratarlo médicamente, hacer un recubrimiento conjuntival, tratarlo durante 6 meses médicamente con fármacos antiamebiásicos, y una vez que el procedimiento esté frío y curado, en el transcurso de 6 meses, un año, lograr una queratoplastia óptica. Con respecto a herpes, ya todos sabemos que no está indicado las queratoplastias con infecciones activas, ya que, como vemos en la diapositiva a la derecha, suele haber una recidiva al poco tiempo, ya sea por estrés quirúrgico o por los esteroides usados en el postoperatorio. Puede suceder esto también alejado en el tiempo. La recurrencia en el dador con una queratitis estromal herpética severa, que no hay otra alternativa que darle tratamiento con aciclovir o con valaciclovir por vía oral, en lo agudo durante 10 días con altas dosis de antivirales, luego se extenderá durante un año para prevenir la probable recurrencia, y en lo inmediato el tratamiento no es otra queratoplastia, sino un recubrimiento conjuntival. Cuando se nos presenta a la consulta una paciente con infecciones corneales graves como una queratoboitis herpética, en este caso con hipopión, no hay duda que el tratamiento es vía oral, y el tratamiento quirúrgico en estos casos, cuando hay chance de perforación, es un recubrimiento conjuntival para enfriar el caso clínico, y tiempo después, una vez que esto esté activo, pensar cuál es la mejor solución. El segundo capítulo es la queratoplastia terapéutica, que todos sabemos que en el caso de infecciones no es el mejor escenario para realizarlo, que solamente lo realizamos cuando son cuadros infecciosos muy severos, con peligro de perforación, y que no responden al tratamiento médico. Mejores candidatos son los bacterianos que los micóticos y los provocados por acantamoeba, que el objetivo primario en estos casos siempre es restaurar la anatomía corneal, dejando con la agudeza visual como un objetivo secundario. Básicamente siempre hay controversia si realizamos queratoplastia lamelar o queratoplastia penetrante. En el caso de infecciones bacterianas, si hay margen libre, probablemente no haya duda que sea penetrante. En el caso de infecciones micóticas, acantamoeba o herpes, si bien hay bibliografía controvertida, en general uno prefiere hacer penetrante y no lamelar. ¿Por qué? Porque estos gérmenes suelen quedar latentes en el estroma profundo. Y en el caso de las micosis, son uno de los pocos agentes infecciosos que pueden perforar la DSMET y penetrar en la cámara anterior, por lo cual una keratoplastia lamelar puede dejar gérmenes en el interior del globo ocular. Este es un caso clínico reciente de una paciente que había tenido una complicación post-LASIK, hizo una infección micótica, le hicimos, como se ve en la foto central, una amputación del flap, tratamiento tópico con antimicóticos, a los 20 días parecía curado, a los 40 días recurrió, y luego de 120 días, ajustando el tratamiento tópico al antibiograma, finalmente fue solucionado. Si lo hubiéramos realizado como dudamos inicialmente el día 20, realizar una keratoplastia lamelar con fines ópticos, hubiéramos obtenido un mal resultado con recurrencia de la infección. Es sumamente importante recordar esto en el caso de las infecciones micóticas. Entonces, si podemos dar algunas perlas, en el caso de keratoplastias terapéuticas, mantener por lo menos 1 milímetro de seguridad, no olvidar enviar material a patología para PCR, para cultivo de antibiograma, tratar en el caso de keratoplastias penetrantes, infecciones severas, no remover el cristalino, que suele ser la única barrera para que esta infección se transforme en una endoftalmitis, y siempre puntos interrumpidos, ya que los puntos continuos pueden ser necesarios quitarlos o que se afloje. En este caso comprometemos la biomecánica total de la córnea. Este es un caso de una infección bacteriana severa por pseudomonas, donde como quedaba margen libre pudimos realizar con éxito una keratoplastia penetrante con buen resultado terapéutico y óptico. Un capítulo pequeño y aparte es que cada vez hay más publicaciones de la utilidad de crosslinking como elemento coadyuvante, no como único tratamiento en el caso de infecciones corneales, exceptuando las virales y las acantamoebas. Nosotros hemos publicado hace algunos años, que tenemos el orgullo con nuestro grupo de participar como referencia del capítulo de crosslinking en infecciones en el libro de Manis, una experiencia con infecciones en acantamoeba e infecciones en hongos. En hongos el resultado por anatomía patológica fue muy bueno, y en acantamoeba los quistes son casi imposibles de erradicar con el crosslinking. Tengamos en cuenta el crosslinking como un evento coadyuvante y no como único tratamiento. Y vamos finalizando con algunos casos. Una infección micótica comprometía toda la córnea, se requirió una keratoplastia de gran diámetro. Tuvimos los dos eventos posibles en keratoplastia de gran diámetro: el primero, que falle la córnea, y el segundo, que hubo recurrencia de infección micótica, y tuvimos que solucionarlo, por suerte, con efectos tectónicos favorables con un recubrimiento conjuntival. Este es un caso de un absceso en lisis, luego de curado el infiltrado infeccioso, sufrió una perforación, y como ya no había cuadro infeccioso presente, fue restaurado con una keratoplastia penetrante con muy buen resultado. Y como última slide les quiero mostrar lo que para nosotros es lo ideal: es doing first the conjunctival flap, second to cut the side parts of the conjunctival flaps, and in the end, when we are sure that the infection is cured, we do a penetrating keratoplasty. Esto es lo ideal y lo que aspiramos en casi todos nuestros casos de infiltrados infecciosos. Como conclusión, recordemos que el flap conjuntival y la keratoplastia penetrante son recursos muy útiles en infecciones severas. El crosslinking es un elemento coadyuvante que hay que tener en cuenta, y que cada paciente y cada caso debe ser tratado como único y irrepetible. Por lo tanto, las indicaciones muchas veces son controvertidas y depende del caso. Muchas gracias por su atención. Gracias, Pablo. Thank you, Pablo.
Thank you so much, Gustavo. Excellent talking. Really, I think conjunctival flap, it's a very, very useful tool, not only in infection, but also in some other cases. Okay, thank you so much. And now our next speaker is Professor James Reidy. He's a very, very brief CV. He's a Vice Chair of Clinical Affairs and Associate Professor. O sea, él es el jefe y profesor asociado de oftalmología en el Departamento de Oftalmología en la Universidad de Chicago. Él es un reconocido experto en córnea, investigador principal de un sinnúmero de trials en córnea y en crosslinking para el tratamiento del keratoconus. Él ha editado para la American Academy of Ophthalmology muchos de los libros del Basic Clinical Science de córnea. Él es autor y many peer-reviewed de numerosas cantidades de papers y de muchos capítulos de libros. Ha obtenido Achievement from the American Academy. Y la verdad que es un gran honor. It's a great honor for us to joining us to share your knowledge. Thank you again, James Reidy, Professor James Reidy. Whenever you want, you can.
Yes.
Screen.
Thank you, Pablo. The pleasure is all mine, and it's an honor to be here amongst so many great ophthalmologists. So I'm going to talk today about peripheral ulcerative keratitis. So autoimmune keratitis is non-infectious ulceration of the cornea, otherwise known as keratolysis. It's not directly associated with trauma, and it's usually autoimmune in nature. So many times you can diagnose an associated systemic disorder, usually of autoimmune origin. Sometimes the patient carries the diagnosis, but many times they come in with the ocular findings without having a systemic diagnosis. And it manifests itself in the eye in a localized way. But usually there are other signs and symptoms of the autoimmune diseases. So quite frequently, autoimmune keratitis, when it occurs more peripherally, but occasionally it occurs paracentrally. It can be unilateral or bilateral, and I would say that if there's a bilateral involvement, it's much more likely to be autoimmune in nature. In active disease, there's always an epithelial defect overlying the ulceration. And when the autoimmune process stops, re-epithelialization occurs. I refer to this as non-infiltrated keratolysis, which means it's unlike a bacterial infection where you see the accumulation of polymorphonucleocytes, you don't see cellular infiltration with this particular type of keratitis. It's typically avascular, and it has relatively non-specific signs and symptoms of redness, tearing, photophobia, and foreign body sensation. And in the case of Morin's ulcer, which is characteristically usually associated with a lot of pain. So corneal stromal thinning, usually there's a separation between the area of thinning and the limbus. It occurs more frequently in the inferior quadrants, but it can really occur anywhere. And like I said before, central or paracentral. The ulceration may remain superficial, but it can progress to desmetocele formation and perforation. And usually there's conjunctival hyperemia adjacent to the area of the corneal ulceration. We'll talk about that more later. The differential diagnosis, which college and vascular diseases specifically have been associated with this disease. Primarily it's rheumatoid arthritis combined with Sjogren's syndrome or Sjogren's syndrome only, polyarteritis nodosa, granulomatosis with polyangiitis, which is Wegener's granulomatosis, systemic lupus, relapsing polychondritis, and even in inflammatory bowel disease, this can occur. So how do we treat this? First and foremost, we have to control the underlying autoimmune process using systemic steroids or eventually systemic immune suppression. Aggressive treatment of the dry eye should occur immediately. Topical cyclosporin or tacrolimus are helpful. Proteinase inhibitors, which we'll talk about. Judicious use of topical steroids, antioxidants, localized conjunctival resection, tissue adhesive and bandage contact lenses when it's appropriate, and tectonic or penetrating keratoplasty as a last resort to prevent penetration and restore the structural integrity of the eye. So let's talk about these things specifically. So antioxidants and proteinase inhibitors. Antioxidants such as N-acetylcysteine, which is for many years been used as a mucolytic by respiratory therapists, is a thiol-containing cellular antioxidant which promotes glutathione synthesis, and it's a potent anti-inflammatory by means of inhibiting oxidative stress. So topical acetylcysteine 10% drops can be effective in a lot of these sterile infiltrations. Direct proteinase inhibitor, already today, oral doxycycline has been mentioned, and that in subtherapeutic doses even it works, 50 to 100 milligrams a day. If there's a lot of rapid stromal melting, I might increase that to 100 milligrams twice a day, at least for a time. Topical EDTA that we use for removal of band keratopathy. The EDTA also acts as a potent proteinase inhibitor. So you might think about that if you have it available to you as a drop. Medroxyprogesterone is an old systemic or intramuscular medication that has found some use in the past as a topical agent to prevent corneal or stop corneal melting. And then finally, chlorhexidine, which we use for acanthamoeba. Chlorhexidine is also known to be a well-known proteinase inhibitor. I've never seen a paper that talks about chlorhexidine topically for peripheral ulcerative keratitis. However, theoretically, it should be helpful. Much of the problem occurs due to the accumulation of matrix metalloproteinases in the paralimbal conjunctiva. This was discovered in the late 60s or early 70s by Richard Eiferman, who did conjunctival resections and measured collagenase in the peripheral resected conjunctiva, where he found large amounts of collagenase accumulating in the conjunctiva adjacent to where the ulceration is. So matrix metalloproteinases, as time has gone on, have been shown to play a large role in these diseases. And these are zinc dependent extracellular endopeptidases, and they play a role in cell behavior and in the degradation of components of the extracellular matrix and basement membrane. They were discovered in the early 60s. And here's a little illustration of how collagenase works and how it's secreted. It can be secreted by the corneal cells, that's MMP1, or by the neutrophils, which is MMP8. The matrix metalloproteases are secreted in a pro form, and they have to be activated in order to work. And this is the sequence in the different chemokines and cytokines that are involved in that activation. For our purposes today, the matrix metalloproteases that play the biggest role are MMP1, MMP8, and MMP13, which the principal substrates are fibrillar collagen, primarily, types 1 through 3, but primarily type 1, and then gelatinase and A and B, which are MMP2 an MMP inhibitor. The principal substrates are non-fibrillar collagens, primarily within the extracellular matrix. There are 22 different kinds of matrix metalloproteases, but in the cornea, these are the ones that are most important. There are, as well as matrix metalloproteases present in our own bodies, we also have inhibitors of matrix metalloproteases. Those are the TIMPs, tissue inhibitors of metalloproteases. There's 4 types, and these moderate and stop the action of matrix metalloproteases, which do have a role to play in our normal bodily functions. The pharmacological exogenous inhibitors I mentioned already, doxycycline, EDTA, and medroxyprogesterone, and there's been a number of synthetic MMP inhibitors, but none have been ultimately approved for use in the eye, at least not in the US. Most MMP inhibitors, the exogenous ones, are chelating agents, and the inhibitor binds to the zinc at the active center of the enzyme and blocks its activity. So what do we do with these patients? Some will present with perforations, some will present with severe ulceration, and in some cases, in near perforation or with small perforations, we can use and apply cyanol acrylic glue to block the perforation or prevent the perforation. Typically, you can use this usually 1 millimeter, 1.5 millimeter perforation. You can use this with, there are some tricks that will close with glue, slightly larger perforations if you use, let's say, tissue glue on top of it or below it. This is available as histocryl, which is the N-butyl form of cyanol acrylate, and that seems to be the most effective form of the glue. And here is a video on how to apply the glue from Dr. Hussain. I'm sorry. Here we go. Just quick. Now this air is in the anterior chamber. There's a small paralimbal perforation and ulceration. We're taking off the epithelium. It's important when you apply glue. Glue does not adhere well to epithelium, so you have to remove the epithelium surrounding the, for a zone around the epithelium, around the ulcer, so it will heal and adhere long enough to allow it to heal. So we're removing the epithelium with a blade and using the Van Ness scissors, and he's going to go in and remove the iris blocking the perforation with a cannula. There you can see the air going through. He'll go in and remove the prolapsed iris. And then you'll see he adds more air just to beyond the area of perforation, very slowly so it doesn't come out. Very nice. And a drop of glue, which is all you need. You don't really need to touch it. Just let it polymerize. It does so relatively quickly. And cut. And then remove the air. And then you have to place a contact lens on over glue. And typically, what will happen is the area vascularizes and then reepithelializes underneath the glue. Usually takes between 4 to 6 weeks. You leave the bandage contact lens on. And again, if there's an underlying autoimmune process, it'll keep melting unless that process is controlled with medication. So for worst cases, there is tectonic lamellar keratoplasty. You can do this if there's a large ulceration and a larger area of the cornea affected. You can do a tissue graft. And here's a video of that by Dr. Ward, Matt Ward from Salt Lake City. So this is a case of peripheral ulcerative keratitis, 67-year-old person with rheumatoid arthritis. And you can see it leaking right there. And it's really affecting a large area of the cornea starting right here. That's the thinner part. And he's dissecting free some of the overhanging fibrovascular tissue. And now going to do a conjunctival resection. So conjunctival resection alone works. If you do this early in the case of somebody coming in, you can do a conjunctival resection right in the office, take about 3 to 4 millimeters of adjacent conjunctiva, leave it recessed, and that will oftentimes stop the process. And it's simple enough to do. You can do it at the slit lamp, or you can do it at in a little minor operative suite that some of us have in our offices. But he's going to do a tectonic lamellar graft, and you have to create vertical edges, ideally, so you have something better to sew, and you get sew to, and you also have a smoother, more normal surface. He's using a tree fine to partially cut and mark the limbal area, which he's using a micrometer diamond knife there. It's a back cutting diamond knife, a little harder to use the back cutting. Front cutting are easier. So he's making a 300 to 400 millimeter cut, and then removing some of the residual stroma. So he has a nice edge to sew to, and he'll freshen up the anterior edge as well. Removing the residual stroma, you can see that nice edge at the limbus. You can make the leading edge primarily in the cornea, or you can do it in the sclera, or you can do it on both sides. It's more important to get to have that nice leading edge in the cornea. So he's removing the other edge of residual stromal tissue. And he's using the diamond knife to kind of create a better, more vertical surface to suture to. And that's just removing some of the residual part. So he's measuring this, and he's going to use a piece of lamellar tissue. And I will tell you now, you cut these with, just like you'd have the eye bank cut it, just like you would for a DSEC, and you use the stromal portion of the graft instead of having to manually dissect it. So, which is what he's doing now, to thin it out a little bit. And that's a lot harder. You can get a nice lamellar stromal graft on a piece of tissue that's not suitable for endothelial transplantation and just have him do a desect cut. So that's what we'll pretend that we're seeing here. He marks it and he's using an 11 barred Parker blade to make the vertical edge. You could use his scissors too, but this might give you he's doing that over the tree fine block, and he has a nice straight vertical cut there with that 11 blade. He put a little bit more tissue there, so he has room to sew it, and then he'll sew this together. And this kind of goes straight across the cornea. You can, if it follows the limbus, you can do a curved limbal tectonic graft, and he's now just suturing it together. And at the end of this, he'll see when he's suturing near the pupil, he's making it somewhat oblique to avoid entry into the visual axis, which is a clever thing to do. And then at the end, he's going to put a amniotic membrane graft over the entire cornea and stitch it together in the limbus to both speed epithelial healing, and also amniotic membranes are inherently anti-inflammatory, so that'll help with the inflammatory response too. Beautiful job, and now he'll put on the amniotic membrane.
I love the amniotic membrane in a case like this.
Yes.
After all.
Yeah, it works really well. I just wish it wasn't so expensive, Pablo. And all the way around, and then after this, if you're doing an amniotic membrane like this, you should do a temporary central tarsorrhaphy, so the amniotic membrane doesn't melt. That's a little technical point. I'm amongst giants here, but for those of you in the audience, maybe some residents, if you're doing amniotic membrane for just about anything, if you want it to do its job, you need to cover it with a tarsorrhaphy, either partial or complete. It'll last a lot longer. Okay, and then finally, lamellar patch grafts can be used. And I'll give you a couple of instances where I've seen a number of cases. They're usually patients with rheumatoid arthritis or Sjogren's syndrome, or just straight rheumatoid arthritis, no history of eye disease, maybe some dry eye. They come into the office, they have a YAG laser, or let's say a retinal laser, where they use a lens in order to do the laser. Everything goes well, but maybe at the end, they have a small epithelial defect, they put them on some drops. And then they come back 3 or 4 days later in pain and redness, and maybe with a leaky eye, because they developed a rapid non-infiltrative ulcer. Oftentimes it's central or paracentral, usually paracentral, and it can occur very rapidly in that scenario. If there's you can use glue, but if there's a larger perforation of 2 millimeters or more, there's tricks that you can do to use glue for that. However, a lamellar patch graft like this works very, very well. And again, you don't need to use full thickness tissue. You can use partial thickness tissue. You don't have to replace the epithelium or endothelium because the perforation is relatively small. So you, again, use that lamellar stromal tissue that you can get from your eye bank, or even now commercially, and cut it. It's usually a smaller tree fine size, and this is just something that you should all know. The standard range of tree fines and most operating rooms go between about 7 and 9 millimeters. Anything smaller or larger, they don't typically, at least speaking for me, everywhere I've been in the United States, that's what they keep. But being a corneal specialist, we know that we have to use larger tree fines sometimes, and in this case, smaller tree fines for lamellar patch grafts. You don't have to do it very often, but it's very, very nice to have those, and they are available to order. Goiter, for example, makes them, but there's probably many other manufacturers that make the smaller and the larger ones. You have to look around, but those are the kind of things that you want to keep in your office. So if somebody comes in and needs something emergently, you have something to use. The other thing I'll tell you is that the use of diamond knives, especially when the eye is perforated and there's a lower pressure, diamond knives just cut much easier, and they're very handy to have either a free diamond knife or a micrometer knife that limits how much you're cutting, so you know a little bit more, but it's easier to use a diamond knife. And just briefly, we'll go over what immunomodulatory agents really work well. Prednisone is the primary one that we're going to use right off the bat because it takes effect right away. If it's very bad, a case of vasculitis, we give IV methylprednisolone. And then in these autoimmune cases, it has to be tapered very slowly. And if they're going to be on it chronically, you need to monitor certain things and give them prophylactic proton pump inhibitors to help their stomach from and prevent ulcers from occurring. I'll divide these secondary second-line agents into alkylating agents, and Cytoxan is the most powerful and the most toxic. Alkylating agents generally are toxic and are not used much, but in cases of severe vasculitis with bilateral involvement, you can give these agents intravenously with rapid onset of action. And in certain instances, IV Cytoxan still has a role. Anti-metabolites are the most common. Methotrexate works very well. It's been around forever. Imuran also works. It has a little greater immunomodulatory effect, but you have to be careful, especially if it's used chronically, especially in older people who might have pre-existing malignancies like prostate carcinoma, whether they know it or not. Mycophenolate mofetil, which is Cellcept, is a more recent one. It's very popular for autoimmune diseases, works well for this. It does have some GI side effects. Areva is not used as much. And then the newest treatment in the block is our biologic agents. The prototype was Remicade. That was the first one that was available. It works. It inhibits tumor necrosis alpha. And Humira, which is a more recent one, possibly more effective, also is a tumor necrosis alpha receptor inhibitor. Alternatives in the biologic field are rituximab, which is a CD20 inhibitor, which is very effective. And then the other two are inhibitors of tumor necrosis alpha as well. They're Simponi and Cimzia are just newer ones. Most of these agents should be administered by a rheumatologist because they're treating underlying systemic diseases. Don't try this yourself at home, boys and girls. Let a rheumatologist or a transplant immunologist help you. But you can't, certainly we'll all use steroids because we're familiar with steroids. But the others, involve a rheumatologist because they have a systemic disease and you need to treat the whole body. So I thank you very much for your attention. I enjoyed being here, and I'd be glad to take any questions if you have them.
Thank you so much, Professor. Really a wonderful presentation. For the audience, really, the cornea is under pressure when you have a disease like this. And it's very important if you decide to go to the OR, to the operating room, to perform a procedure, a lamellar procedure. Because
yes,
you do a penetrating, perhaps it's going to be a nightmare. I don't know if Rajesh agree with me, I don't know. Okay, now we are tight time. The next speaker is Hugo Scarfone from Argentina. Hugo Scarfone es un gran cataract surgeon and also a LASIK surgeon, refractive surgeon. And well, he's going to share with us his experience doing phaco in patients with RK. Gracias, Hugo.
Hola, Pablo.
Por favor.
Sí.
Muchas gracias.
Muchas gracias por la invitación y por la oportunidad de poder compartir con ustedes. También voy a mostrar mis slides ¿Comparto la pantalla, Pablo?
Por favor.
Voy a mostrar mis slides en inglés, como quedamos, pero voy a dar la presentación en español. No es fácil, después de la calidad de los oradores que tuvimos, la complejidad de los casos y el impresionante nivel científico de los conocimientos que nos transmitieron. Después de semejantes presentaciones me siento como la nada misma, es la realidad.
Please don't be modest. Great surgeon.
Honestamente es así. Quiero felicitar a todos los disertantes. Fueron increíbles las presentaciones. Repito,
Vamos, Huguito, eso es un maestro.
Es un honor. Bueno, la presentación mía es bastante sencilla y básica. Facoemulsificación en pacientes con queratotomía radial previa. En general son casos más complicados. Debemos frecuentemente enfrentarnos con astigmatismo irregular, así que debemos ser cuidadosos, ya lo veremos más adelante con el implante de lentes tóricos. Normalmente la biomecánica corneal en estas situaciones es inestable, lo que genera fluctuaciones refractivas. Muy importante a considerar en los posoperatorios, los cuales muy probablemente en lo inmediato tendremos situaciones que quizás no son las esperadas, pero debemos ser pacientes. Normalmente lleva algún tiempo la estabilización. En general podemos observar queratometrías de valores extremos, lo cual es sumamente desafiante para el cálculo del lente intraocular y lo hace bastante menos predecible que en situaciones normales. Y podemos también presentarnos frente a complicaciones intraoperatorias más frecuentemente, específicamente una de ellas que es la que vamos a ver, que es la perforación corneal. Entonces, en primer lugar, cuando enfrentamos una cirugía de catarata en un paciente con una RK previa, debemos saber que la dificultad es proporcional al número de incisiones radiales. Lo primero que debemos observar es si hay algún lugar donde podemos ubicar nuestra incisión principal. En el caso de que esa respuesta fuese afirmativa, bueno, ¿dónde colocarla? A veces no es el lugar habitual de ubicar nuestras incisiones y eso puede generar una situación intraoperatoria de incomodidad para el cirujano. Y en el caso de que no tengamos, estas son cirugías de queratotomías radiales que obviamente no se realizan en el presente, son cirugías antiguas. Nosotros, en el lugar donde yo me desempeño, tuvimos 30, 40 años atrás una altísima incidencia de queratotomías radiales con múltiples retratamientos, y frecuentemente nos enfrentamos con pacientes donde no es una queratotomía común y corriente de 4 u 8 cortes, sino que tenemos algunas de más de 30. Entonces, verdaderamente no tenemos ningún lugar donde poder ubicar la incisión, y en ese caso debemos optar por una incisión escleral, que a veces no es suficiente porque en algún momento debemos atravesar la córnea para llegar a la cámara anterior. Entonces es aconsejable, como podemos ver en estas fotografías de la derecha, previamente a la cirugía colocar un punto para prevenir la ruptura de las incisiones. En cuanto al cálculo del lente intraocular, el mayor desafío es poder medir correctamente el poder corneal. Lo aconsejable es utilizar múltiples elementos de medición, todos los que ustedes conocen y están disponibles, no me voy a detener en esto. En mi caso particular, utilizo habitualmente para realizar el cálculo del poder esférico el calculador online de la Sociedad Americana de Cirugía de Catarata y Refractiva. He obtenido resultados aceptables y satisfactorios con el mismo, y en general debemos saber que hay que estar preparado para la sorpresa refractiva, y muy importante, un tema que debe tratarse con antelación con los pacientes. En relación al implante de los lentes tóricos, en general, si el astigmatismo es regular, estoy a favor de eso, implanto lentes tóricos. Vemos acá sobre la izquierda unas fotografías de reconstrucción de una córnea con múltiples cortes, pero a pesar de eso, una topografía con un astigmatismo regular. Implantamos un lente tórico sin problemas y con resultados satisfactorios. Y en el caso de presentarnos frente a situaciones de astigmatismo irregular, si bien sabemos que esta no es la indicación básica de una lente intraocular tórica, en algunos casos seleccionados, considerando algunos ítems, también podemos implantarlos. Y en estas situaciones debemos observar que ese astigmatismo irregular sea bajo en la parte central de la córnea. Un tip que puede ayudarnos a inclinarnos por el sí o por el no es si la refracción subjetiva, la corrección cilíndrica subjetiva del paciente coincide o se correlaciona con las mediciones keratométricas en cuanto al eje y al poder. En situaciones donde hay muchas incisiones, quizás no sea lo más apropiado. El paciente debe tener expectativas reales, y si podemos conciliar estos puntos, a veces también podemos tener buenos resultados. En general, en las situaciones en las que tuve dudas y no implanté los lentes tóricos, en el postoperatorio siempre tuve la sensación debí haberlo hecho. Así que ante las dudas, si las condiciones mencionadas anteriormente se cumplen, creo que es lógico proceder con un implante tórico. Como un tip a considerar, acá observamos una topografía con escalas ajustables que son las que habitualmente utilizamos para ojos con keratometrías que rondan en valores normales. En el caso de las keratotomías radiales de muchos cortes, la córnea tiene aplanamientos muy significativos. Entonces lo que debemos hacer, un truco para poder observar más en detalle la parte central de la córnea, como veíamos recién, es modificar las escalas de medición, y eso nos va a dar un detalle más aproximado de lo que está ocurriendo en la parte central de la córnea. Vamos a ver un caso de un paciente en el cual implantamos un lente tórico con una keratotomía radial previa. En el caso de tanto del queratómetro automático como el biómetro óptico, las mediciones de las CAS estaban fuera de escalas. Las que obteníamos en la topografía no nos conformaban al 100%, así que en estas situaciones es muy útil la utilización de los queratómetros manuales. Con los queratómetros manuales es muy raro que no podamos medirlo y generalmente nos dan una medición más aproximada. En este caso, en función de las queratometrías manuales y observando que el astigmatismo era regular a las miras del Jabal, decidí implantar una lente tórica. Vamos a ver la cirugía. El eje de la incisión coincidía con el eje de implantación del lente, y al finalizar la cirugía y retirar la pieza de mano del faco, se abrió, como pueden observar, la incisión. En esa situación, lo que debemos hacer es colocar un punto perpendicular a la incisión radial. Debemos tener cuidado de no aproximarnos demasiado al resto de las incisiones, porque a veces eso genera que también se abran, o a veces es necesario, como vimos al comienzo, abarcar 2 o más incisiones con el mismo punto de sutura. Lo importante es que si observamos que alguna de las incisiones se abrió, inmediatamente debemos detener la cirugía, colocar el punto y continuar, porque de no hacerlo puede seguir extendiéndose la ruptura de la incisión. En este caso teníamos programado el implante de una lente tórica. Decidimos con cierta audacia, a pesar de la apertura de la incisión, colocar el implante. Y otro tip importante en estos casos, es muy importante colocar una lente de contacto, porque a pesar de los puntos puede permanecer el seidel en las incisiones. Así que colocar una lente 24 a 48 horas. Este es el postoperatorio del paciente a las 48 horas y la evolución fue satisfactoria. Acá tenemos otro paciente, también con infinidad de incisiones. Esta era una doctora, una médica psiquiatra. También decidimos hacer la faco, en este caso sin una lente tórica. Las incisiones radiales, a pesar de que puedan llevar muchísimos años, a veces más de 30 o 40, son sumamente frágiles, así que debemos ser muy cautos con toda la cirugía. Es una cirugía mucho más delicada. Debemos tener mucho cuidado en el lugar donde ubicamos nuestros accesos a la cámara anterior. Y a veces debemos recordar que no solamente es importante la incisión principal, sino también la incisión accesoria o de la paracentesis, como vamos a ver en este caso, donde por tratar de no forzar la incisión principal, se abrió la accesoria, como van a observar en ese lugar. El riesgo mayor de estas situaciones no es solamente la inducción del astigmatismo, sino que son bastante difíciles de cerrar, a pesar de que coloquemos puntos de sutura. Ahí podemos ver el seidel por esa incisión. Y en general, colocar puntos en una incisión a veces produce la apertura de las vecinas. Entonces, importante el implante de lente de contacto, y recordar que estas son situaciones donde los procesos infecciosos, es decir, la endoftalmitis postoperatoria, es más frecuente o el riesgo es mayor. Creo que estoy bien por acá con el tiempo, Pablo. No sé cómo estás.
Ok, listo. Estoy medio corto.
Perfecto. Listo. Hasta acá llegamos entonces.
Thank you so much. Yeah, it's very, very nice presentation. It's very, very difficult, the IOL calculation in patients like this. He has a great experience in cases like this. So to finish, I'd like to share with you. No puedo compartir la pantalla, Sergio.
Yo salgo.
Ok, thanks.
Ahí sale Huguito. Muy bueno, Huguito. Gracias.
Okay. Can you hear me? It's okay. I'd like to share with you really it was a corneal nightmare in this webinar about cornea under pressure. This is a patient, a female patient who was treated more than 2 years about herpes. No sample at all, no culture. And well, you can see the cornea is not pretty well. Looks, you can see the leukoplakic nodular lesion, the mild conjunctival injection. So what I decide in this situation is go to the OR, and what I decide to do is a biopsy. And usually when I perform a biopsy, I use an amniotic membrane. You can see the results. You can see the abrupt transition between these plastic epithelial cells. So I asked to another colleague, Dr. Leonardo Alessandro, and we start with metramycin, with interferon, and just 1 month after began the treatment, you know what's going on. So I took a sample and a fungal keratitis. We start with voriconazole here. And because of the neoplasia, we were very, very concerned. And you can see the melting. So I had to decide to go into the OR. To perform a PK in an eye with a perforation is not easy at all. You can use another kind of trifine, the old trifine, just mark. And then what I decided is to use the scissor. Utilicé un trépano grande. What I used was a large diameter trifine. And then I put the stitches like usually I do. But I was worried about the future. It pops up immediately, looks pretty nice. And then I had to decide to perform the cataract surgery. It was not easy at all. This is for 4 months after the first surgery, because I can't see very well. I use tritone blue. I was ready to perform a posterior vitrectomy just in case the constellation was ready, because I didn't see well. Really, it was an extremely difficult surgery for me. But I can put the IOL perfectly. Perhaps I was lucky. Just in case, I put steroids to see what's going on in the anterior chamber, and then I put the IOL. But the post-op looks nice, but the intraocular pressure increased, so I decided to put a tube, because you know the glaucoma post PK is going to be a nightmare, and it was. So I put an AMET tube like always. And it works. Now you can see the post-op, immediately post-op. But again, the problem with stem cell deficiency, you know. Well, the cornea look pretty well, so I decided a second PK procedure. Now you can look the fibrosis. Se puede ver la fibrosis. Este es el segundo PK. What I decided is to wear sclera to take out the conjunctiva, the conjunctivitis. Take it out, all the corneal opacities, and then again, this kind of trephination, large diameter trephination, I think is the only option for a situation like this. The cornea under pressure. Was under general anesthesia, of course, no. I put OPD, and then I finish the procedure. Dornier corneal graft. I put the stitches. And then again, the amniotic membrane because of the stem cells efficiency. And this is the post-op immediately. You can see here the amniotic membrane, the pinhole amniotic membrane, and 10-day post-op. But okay, I'm worried about this patient because I don't know what's going on in the future. Perhaps you can give me some advices about a patient like this with an aplasia. Thank you so much.
Excellent presentation, Pablo, as usual. Great job.
A lot of surgery. I don't know, perhaps Professor Florakis, Professor Reidy can tell me, can give me any advice about the patient with an aplasia.
How often do you use amniotic membrane in these cases, professors?
Me?
No, to the other professors. Yes.
Well, the amniotic membrane will not replace a limbal stem cell deficiency. So if the limbal stem cells are indeed damaged, then you may have to do a limbal stem cell transplant, which has its own set of problems because either you have to take it from the other patient, from the patient's other eye, which they normally do not want you to touch, or you have to have a living related donor or a cadaveric donor, all of which requires immunosuppression, which is also difficult. And also the long-term longevity is poor once you stop the immunosuppression. So, yes, I do use amniotic membrane, but that's only as a temporary attempt to help it heal quicker. If there's true limbal stem cell deficiency, it's a much more difficult situation to treat. And I think in severe limbal stem cell deficiencies, and this may or may not approach that severe of a situation, sometimes even a keratoprosthesis is an option because of the issues with limbal stem cell transplants.
Okay, thanks. But the patient doesn't want to get out the another eye, so that's the reason.
And that's usually the case in my experience. They don't want to touch their other eye. I don't blame them.
I understand the situation.
Pablo, I have a question about this patient. So the original diagnosis was an undiagnosed squamous cell carcinoma that invaded the cornea. Is that right?
Yeah.
So then you have to assume that squamous cell carcinoma came from the conjunctiva and then secondarily invaded the cornea. So how long was he treated with the interferon, and is there any worry about any residual tumor in the conjunctiva?
Of course, you got it. That's the reason when I decided to go to the OR, I was concerned about that. By now, therefore, almost 2 years, I performed confocal microscopy, but well, he couldn't find any cell, but who knows? Because usually, what I think is, it's very probably I need a third corneal graft.
Yes. So a very simple thing to do to look for abnormal epithelial cells in the conjunctiva, and I know you know this, is vital staining. I like lissamine green. And if you stain the residual conjunctiva with lissamine green and you don't get the staining, then I think that's a pretty good indication that you controlled the cells. And then your problem remains stem cell deficiency. So you could do rather than taking it from the other eye, which you'll be reluctant to, you could look to see if he has any siblings. This is an older gentleman, is that right? An older man? What age is the patient?
42 years old.
Okay, so he's not old. See if he's got any brothers or sisters and do an HLA match. And you could possibly just do a limbal graft. If he's got a close sibling match, you could use, you get the tissue from a HLA match sibling, and that's a lot less invasive actually, and it doesn't really endanger the siblings. So if he's got a large family and he's got siblings and they're in the area and they would be willing to donate some tissue, that might be a good way to go. He would still probably need, if it's even if it's a 100% match, he would probably still need to have immunosuppression. And if you didn't do that, then your only other option is a keratoprosthesis, which is a slippery slope, and that's coming from a person who's done quite a few keratoprostheses. That's the last resort in my mind.
Okay, thank you thank you very, very much. I appreciate your advice. Thank you all. This was an honor for me, this webinar about cornea under pressure. Thank you, George. Thank you, Professor James, Rajesh, and all the local speakers. I know we are living a very, very strange moment because of the COVID. I deeply appreciate your attitude and to be here in this webinar. En nombre del Consejo de Oftalmología, muchísimas gracias. Thank you very much.
Thank you very much. Thank you.
Thank you very much,
See you soon.
George, James, and Rajesh.